You might have seen patients complaining of excessive watering from eyes. Most of the cases they are referred from ophthalmology departments to ENT, and that is dacryocystitis, that is infection or inflammation of the lacrimal sac. So today I will explain what is dacryocystitis, what are the etiology of causes of dacryocystitis, the pathogenesis behind that, and how to diagnose, and what is the treatment of dacryocystitis. And also I will explain the anatomy and flow of tears. So I already told you that there is inflammation of the lacrimal sac. So normally the tears flow through the nasolacrimal duct into the nose, and whenever there is an obstruction of the nasolacrimal duct, there will be excessive collection of tears inside the lacrimal sac. And when there is infection, this lacrimal sac will bulge where in the face, that is on the infromedial aspect of the medial canthus. This dacryocystitis is appreciated clinically also. Okay, so on the left eye, okay, so there is lacrimal gland is situated here on the lateral surface. Okay, lacrimal gland, and through this ducts the tears will come into the eyes, and when it reaches, after doing its work in the eye, when it reaches there is upper punctum and there is lower punctum, and from the upper punctum there is upper canaliculus and there is also a lower canaliculus, and there is a common canaliculus. Okay, and this common canaliculus will come and form drain into the lacrimal sac. So this is upper punctum and this is lower punctum. Upper canaliculus, lower canaliculus and common canaliculus. And from the lacrimal sac there comes the nasolacrimal duct, which opens into the inferior meatus. There are two valves in this pathway. One is at the junction of this common canaliculus into the lacrimal sac, that is valve number 1, and another one is at the distal end where it opens into the inferior meatus, valve number 2. So this number 1 valve is called the valve of Rosenmuller. Okay, valve of Rosenmuller. What is there is also another Rosenmuller. What is that? That is fossa of Rosenmuller in the lateral wall of nasopharynx, which is a common site of CA nasopharynx. This is at the junction of the common canaliculus with the lacrimal sac. And at the lower border there is valve of Haisner. Okay, valve of Haisner, right? So, and actually this, here comes the nose, your septum, superior turbinate, then the middle turbinate and also inferior turbinate. Okay. Okay. So the lacrimal sac is actually in the middle meatus, and the valve of Haisner through which the nasolacrimal duct opens into the inferior meatus. Okay. So this is how the tear flow after production from the lacrimal gland. Dacryocystitis can be divided into, one is acute or chronic, or again it can be divided into congenital and acquired. Okay, acute and chronic, congenital and acquired. And the acute dacryocystitis is mainly due to infections. Can be due to staphylococcus or streptococcus infection or H. influenza, or it can be due to Pseudomonas aeruginosa infection. And this chronic dacryocystitis is mainly due to repeated infections or systemic diseases. Which are systemic diseases? That is sarcoidosis, then SLE, systemic lupus erythematosus, and also vaginous granulomatosis. These are the systemic diseases which causes chronic dacryocystitis. It's usually asked in MCQs. Sarcoidosis, systemic lupus erythematosus and Virginous granulomatosis. Okay, so acute to chronic is over, and in acquired, what are the conditions or causes of acquired dacryocystitis? One is trauma to this area, and mainly the trauma is traumatic dacryocystitis is seen with the nasoethmoid fractures. Okay, again that's an MCQ. So nasoethmoid fractures are the most common cause of traumatic dacryocystitis. So one is trauma, and then surgeries. What are surgery? Surgeries are mainly endonasal and endoscopic sinus surgery are the surgeries associated with the dacryocystitis, and some medicines. Which are medicines? So all these medications, timolol, pilocarpine, dorzolamide, trifluridine and fluorouracil. Of this, the fluorouracil is the commonest drug which is associated with an dacryocystitis, and also we have tumors, primary neoplasms of the lacrimal sac, and also papillomas. So all these are causes of acquired causes of this dacryocystitis. And regarding congenital dacryocystitis, before delivery, this whole of this lacrimal apparatus is filled with amniotic fluid. So there is a membranous septum at the level of valve of Haesner in before delivery. So after delivery, usually this membranous septum dissolves or it opens, and all this amniotic fluid will get drained out from the lacrimal apparatus or from the lacrimal sac. When this membranous septum is persisting, so what will happen? Whole of this amniotic fluid will get collected within the lacrimal sac, and after delivery this will cause infection and it will cause dacryocystitis. So that is a cause of congenital dacryocystitis. And this congenital dacryocystitis get manifested immediately after delivery, and it is, though very rare, it is more commonly seen in female children than in male children. And what is pathophysiology of dacryocystitis? That is mainly the obstruction at any level. Okay, from here, at any level, if there is obstruction, it will cause collection of tears. So the tears will get collected inside the lacrimal sac. So whenever there is stagnation of tears, the infective organisms, as I already told, can be Staphylococcus, Streptococcus, H. influenza or Pseudomonas aeruginosa. It will propagate, and there will be collection of proteinaceous or protein-rich debris. This will cause inflammation of this lacrimal sac, and it will present as a swelling in the infromedial aspect of the orbit. Clinically presenting as a swelling. So that is a pathophysiology. And what will you see in histopathology? In histopathology, commonly in chronic dacryocystitis, there is fibrosis and there is non-granulomatous inflammation. That is the common histopathological finding in the case of chronic dacryocystitis. But in some cases, there will be sarcoidosis or lymphoma or papilloma can also be seen associated with this chronic dacryocystitis. About history and examination. So in acute case, it can be either acute or it can be chronic. In acute cases, there will be patient may complain of swelling on the infromedial aspect. This part, infromedial aspect of the orbit, the patient will present with swelling and also tearing. And on examination, at this point, there will be, this is lacrimal sac, so the corresponding area will be swollen and also it will be reddish, erythematous, and can be tender. Okay, so edematous, erythema and tenderness of the swelling on the infromedial aspect of the orbit. It is usually seen in acute dacryocystitis. And on pressing this swelling, the pus can be seen coming out from this lower punctum or from the upper punctum. And in acute cases, there will be excessive tearing and also there will be film. Tear film will be seen between the on the conjunctival sac, and visual acuity may be affected in some cases. So there will be a swelling on the inframedial aspect of the orbit, and which is erythematous, edematous and tender swelling, and there will be regurgitation of pus from the lower and also from the upper punctum, and there will be a tear filming, and also there will be reduced visual acuity. But the conjunctival congestion is usually not seen in case of dacryocystitis, and also pain on movement of the eye is not seen in acute or chronic dacryocystitis. So if there is an complete involvement of the conjunctiva either with redness or there is pain and on extraocular muscle movement, extraocular eye movement, then it should raise a suspicion of another diagnosis, alternative diagnosis. They are usually not associated with dacryocystitis, and in case of chronic dacryocystitis, there won't be any swelling here, and usually tearing is the only symptom seen in case of a chronic dacryocystitis. Evaluation of patient, how will you evaluate? The clinical diagnosis is mainly by history and also by physical examination. I already told you about the swelling on the inframedial aspect of the orbit, and in acute cases it will be tender, edematous and erythema will be present, and also there will be flow of, or there will be, the discharge will be coming out, purulent discharge will be coming from the lower punctum and also from the upper punctum, and also there will be extensive tearing from the eyes. And you can give a Krigler massage. Okay, what is that? This is the treatment of dacryocystitis in congenital dacryocystitis. In children you give Krigler massage, that is massaging, this round massaging. I will explain in detail later on. So you can massage on the lacrimal sac, it's called Krigler massage, and the exudate will be expressed from the lower and upper punctum, and that can be sent for cultural sensitivity culture and also gram staining. Okay, if there is any doubt in your diagnosis, send an ophthalmological consultation, and if there is extensive involvement of the orbit or cellulitis, or there is orbital involvement, do a CT scan of the orbit along with the nose and PNS. Okay, so evaluation is mainly by history, then clinical examination. You can send the pus after doing a Krigler massage. You can express the exudate of pus, and that can be sent for culture and gram staining, and go for a CT scan if there is an orbital cellulitis or you suspect an extensive infection. And in doubtful cases, you can even go for a plain film dacryocystogram, DCG. Okay, this plain film will be enough in case of dacryocystitis. A subtraction DCG will give only a better imaging films. That is not of much help in case of diagnosis of a dacryocystitis. And also in case of chronic dacryocystitis, I already told you systemic infections are usually the cause of chronic dacryocystitis. So appropriate serological testing can be done, like an anti-nuclear antibody ANA testing in case of SLE, and also an ANCA, anti-neutrophilic cytoplasmic antibody testing in case of vaginous granulomatosis can be done. So these are the methods of evaluation in case of chronic dacryocystitis. Usually by history and by clinical examination you can very well diagnose a case of dacryocystitis. Next is treatment. Treatment, we can divide it into congenital and acquired. Acquired, again we can divide it into acute and chronic. In acute dacryocystitis in adult acquired condition, it's usually managed conservatively. Okay, what all things? Over the lacrimal sac we can give hot compress, hot fomentation, or a Krigler massage of the lacrimal sac, or if there is signs of infection, we can give oral antibiotic, and if the patient is too toxic to tolerate the systemic antibiotic, then intravenous antibiotics can be given. The empiric antibiotics, till you get the result of culture sensitivity, should include coverage for both gram-positive and gram-negative organisms. That is important. And in chronic dacryocystitis, and also this lacrimal probing is not advised in case of acute cases. And in chronic dacryocystitis is always surgery. Okay, that is recurrent attacks of dacryocystitis. We call it as chronic dacryocystitis, and surgery is the treatment for chronic dacryocystitis. What all surgeries you can do? This first thing, anyway, the block is somewhere here. So through this, a lacrimal probe can be introduced, and it can be introduced up to the distal end. So if there is any blockage there in the system, it will be relieved. So lacrimal probing is a very good thing. And another surgery with high success rate is an endonasal endoscopic dacryocystitis. As ENT surgeon, we prefer an endonasal endoscopic dacryocystitis than a percutaneous DCR. Okay, and you can also try a balloon dacryoplasty or a nasolacrimal intubation or nasolacrimal stenting. And I'll upload the video of endoscopic endonasal dacryocystitis immediately after this. So just for theory part, I already told you that here comes the nasal cavity. Endoscopic endonasal DCR is one of the easiest surgeries in ENT. And there is obstruction of the nasolacrimal duct, so that this normal free flow of tears is not happening into the inferior meatus or into the nose. So that there is collection of tears inside the lacrimal sac, and this causes reverse flow of tears through this, and you have this epiphora, isn't it? That is what is happening. So in an endoscopic endonasal DCR, you are going directly into the lacrimal sac, removing the medial wall of the lacrimal sac, so that what will happen? These tears will bypass this area and it will flow into the middle meatus, and it gets swallowed through the pharynx and into the oropharynx. Okay, so that is endoscopic endonasal DCR. You go through the middle meatus using an endoscope, middle meatus, identify the lacrimal crest, which is seen immediately anterior to the attachment of middle turbinate to the lateral wall. Make a window, cut a window over that, then remove the bone of that area, then identify the lacrimal sac, then remove the medial half of the medial wall of the lacrimal sac. It's done. It's a very easy surgery. It can be done within 5 to 10 minutes, and can be done under local anesthesia also. Okay, so that is endonasal endoscopic DCR. And in congenital dacryocystitis, it is in most of the cases, in 92% of cases, it is conservative treatment which gives excellent results in case of congenital dacryocystitis, and usually the child will recover within 6 months to 1 year with conservative treatment. That is mainly by the Krigler massage. And what is this Krigler massage? This Krigler massage can be started immediately after identifying a child or a newborn with dacryocystitis. And how will you do that? So I'll make a big one on the right eye. This is orbital rim, okay, and upper punctum, lower punctum, upper canaliculus, lower canaliculus, and the common canaliculus. Then comes the lacrimal sac and the nasolacrimal duct on the right side. And ideally, this, I already told you that the persistence of a fetal membrane at the distal end of the nasolacrimal duct, or at the level of valve of Hasener, causes this blockade or it block the flow of tears into the inferior meatus. So on the right side, so for the right side you keep a right thumb over the lacrimal sac area in such a way that this nail should be outward, and this should not allow this reverse flow of tears into the orbit or into the conjunctival sac. This should not go into the conjunctival sac. This should be pressed downwards, and from the right side you go right downward, and the movement of the thumb should be in this direction. This should press on the lacrimal sac. At the same time, this should be rotated downwards so that the tears will come the right way. This will burst open and it will go into the nasal cavity. So if it is on the right side, you keep your right thumb on the over the lacrimal sac, and care should be taken not to allow regurgitation of these tears into the conjunctival sac. Okay, and you press downwards. This should go downwards, right? So that, as I already told, this tear from here will go and burst open this membrane over the congenital membrane, and the flow will be retained. This can be repeated up to 6 months to 1 year. Okay, and this should be taught to the parents or to the caretakers of the infant or the newborn, right? So that is crigula massage. In more than 90, that is up to 90 to 92% of cases, the child will be better used by this crigula massage. If not, all the surgical methods can be adopted. Okay, but you have to wait minimum for 1 year for correction of this dacryocystitis, right? So that is a treatment in case of congenital dacryocystitis. You should be careful not to do this crigula massage at the time of an acute attack. In both adult and in children, you should not do a crigula massage at the time of acute dacryocystitis, and this can be continued even if the child is waiting for an invasive surgery. Okay, and for completion's sake, I'll also tell after treatment the differential diagnosis. What are the differential diagnosis of this dacryocystitis? That paranesis sinus comes here. So the ethmoid sinusitis, complications of ethmoid sinusitis or the frontal sinusitis, all can mimic an dacryocystitis, and also any neoplasms of this area. Already told you, lymphoma or dacryoadenitis can mimic a dacryocystitis, and also a sebaceous cyst or a lipoma. Any swelling in this area comes in the differential diagnosis. So that is all about dacryocystitis. I explained about what is dacryocystitis, what are the types, both acute and chronic, again congenital and acquired. Then pathophysiology, I already told you, histopathology, and this can be diagnosed very easily by doing taking a proper history and examination. Okay, and treatment in acute cases, that is conservative management, and in chronic, for ENT surgeon, the preferred endoscopic endonasal dacryocystostomy. Okay, thank you.